Mills, you can come forward, sir. We are running slightly behind schedule, but don't worry, we'll be done in time.
Could you pass it to me? I've rewritten if you could just put it on the hard drive quickly.
So, Dr. Mills is a general and dedicated preventative cardiologist. And he's got over 3 decades of practice experience, and he has published quite worldwide, looking at the success of aggressive cardiovascular risk reductions, utilizing a new and better understanding of lifestyle, nutrition, and exercise protocol, which is grafted onto a new powerful pharmacotherapy. So we welcome Dr. Mills.
Thank
Managed to get the,
Yeah, I did. Thank you very much indeed. It's an absolute privilege and a pleasure to be here, and thanks to Novartis for giving me the opportunity to give you some insight into 3 decades of my life as a preventative cardiologist. The World Health Federation and the WHO continually remind us that cardiovascular disease is the #1 killer in the world. And this talk actually follows on very nicely from the last talk. 1/3 of all global deaths are caused by cardiovascular disease. It's not rocket science, because there's one pathological process that is responsible for 85% of all the cardiovascular deaths in the world, and it is atherosclerotic cardiovascular disease. And to put the pandemic into perspective, you've got to remember that in 4 years, COVID internationally has killed 7 million people. Cardiovascular disease has killed 70 million people. What a lot of people don't understand, as a preventative cardiologist, this is my mandate. 90% of this pandemic is entirely preventable. The problem is that 50% of the epidemic, it's not your fault. It's a genetic heritage that you've picked up from your ancestors. The other 50% is due to poor lifestyle. And in fact, just last month, the World Heart Federation asked us to take stronger action against cardiovascular disease. The problem with atherosclerotic vascular disease is that it has a very long silent phase. So many individuals, by the time they're in their 30s and 40s and are completely asymptomatic, have quite advanced atherosclerotic vascular disease, which is entirely silent until the acute event. So the challenges of lipid lowering in the 21st century are the following. In the past, healthcare systems have been preoccupied with treating disease and not preserving health and not preserving functional state. I mean, that's what quality of life is all about, is to preserve our functional state. We need to change this narrative. It cannot continue that we just are preoccupied with treating disease. Healthcare systems do not focus on the lifetime risk of atherosclerotic vascular disease. It is this time in life that we should be maximizing our preventative strategies. And we need to now consider a new paradigm. We need to consider an individual's lifetime exposure to the so-called atherogenic lipoproteins. And this graphic tries to show that on the y-axis there's a cumulative cholesterol exposure in your life, much like smoking pack years. And there is a threshold in that dotted line as to the onset of atherosclerotic vascular disease in your lifespan. Remembering that 50% of this disease process is genetically linked. We have strong genetic drivers of hypercholesterolemia, familial hypercholesterolemia, and filial combined hyperlipidemia, and this generates the crossing of the threshold for atherosclerotic vascular disease very early in life. And so we take our guidelines from the World Health Federation, and they've given us 8 pillars of the role of the ApoB and cholesterol in atherosclerotic vascular disease. The first point, and I still find a lot of skeptics around the world who do not believe that atherosclerotic vascular disease is a disease of lipoproteins. It's the retention of the atherogenic ApoB lipoprotein in the subendothelial space, and this is cumulative over our lifetime. Cholesterol and triglyceride, as you know, are fats. They're insoluble in the plasma, so they are carried by these particles called lipoproteins. Now, we define the ApoB lipoproteins as the 4 atherogenic lipoproteins in our bloodstream. The commonest being LDL, then VLDL and IDL, and the 4th one is lipoprotein little a, and I'll tell you a little bit about more in the future about lipoprotein little a. But these are the 4 atherogenic lipoproteins that cause all the atherosclerotic vascular disease that we're familiar with. The second pillar is that atherosclerotic vascular disease is multifactorial interaction with the ApoB lipoproteins in the center of all the risk factors. And the last presentation highlights the importance of all the peripheral factors: insulin resistance, cancer survivors, high inflammatory markers, obesity, overweight, blood pressure. They work through the atherogenic lipoprotein in that they damage the endothelial lining to make the arteries more permeable to the atherogenic ApoB lipoproteins. But in fact, if you remove these entirely, it's interesting, the peripheral factors have less of an influence on the role of vascular disease. The third point, which seems to escape most people, is that atherosclerotic vascular disease is not seen with extreme levels of elevated LDL cholesterol. In fact, 50% of the acute vascular events occur in people with otherwise normal LDL cholesterol levels of less than 3.0 millimole per liter. The genetic causes, as I indicated, 50% of all vascular disease is genetically driven. It is not your fault. And you can't fix a genetic problem by being a good individual, unfortunately. You have to involve modern pharmacology to fix the 50% of genetic problems, and they are way underappreciated, ladies and gentlemen. Heterozygous familial hypercholesterolemia is the most commonest monogenetic disorder in the world. 1 in 300 people have heterozygous familial hypercholesterolemia, an autosomal dominant monogenetic disorder. In South Africa, we have a prevalence of 1 in 70 to 1 in 200. If you look at any registry in the world, less than 10% of the population is even diagnosed with familial hypercholesterolemia. and less than 1% of our population are treated to the guideline prescribed goals set by our mandate body, the European Society of Cardiology, which is an LDL cholesterol level of less than 1.4. Premature atherosclerotic vascular disease is seen in most males between the ages of 35 and 45, and females will have their first event anywhere between 45 and 55. And 14%, 1 in 6 men and women who have an acute coronary syndrome less than 40 years of age will have heterozygous familial hypercholesterolemia. And so it is our opportunity and our mandate to cascade screen family members of index cases. And in fact, I have found over my 30 years of practice that I find 7 new cases of undiagnosed heterozygous familial hypercholesterolemia when I cascade screen 1 index patient who's had an event. 20% of the population has moderate to severe genetically driven elevation of lipoprotein (a), and 1 in 100 to 1 in 200 individuals, which means in this room alone, there are 2 to 3 individuals who have got polygenetic familial combined hyperlipidemia. And these, ladies and gentlemen, are the genetic conditions that are all classified as very high cardiovascular risk, and they need a pharmacological approach. The 5th pillar is one of the most important pillars that I give my clients, because there's hope. We can switch off this process entirely, and we can reverse it. In fact, we can switch it off directly related to the degree of atherogenic lipoprotein reduction, and I'm going to show you a very important study in a moment. And it's important that this takes place over a long period of time, in other words, early in life. And we know that if you want progression of the disease, any LDL cholesterol above 1.8 will see progression of atherosclerotic vascular disease, but we will see regression of atherosclerotic plaque progressively lower with LDL cholesterols of 1.8 or a so-called ApoB level of 0.5 or an ApoB, ApoA1 level of less than 0.3. And I strive for this in tens of thousands of patients, and we show aggressive plaque regression in these individuals. Although LDL cholesterol is still our conventional endpoint, and probably most of you in this room will still be using LDL cholesterol as your mandate in treatment and diagnosis, we have new directives from the European Atherosclerotic Society and the European Society of Cardiology that we should be using the ApoB level. And it's a standard pharmacological test now as an additional target. And the reason for this, ladies and gentlemen, is because of this pillar, number 7. Because we've got such high levels in sub-Saharan Africa of metabolic syndrome, your last speaker spoke eloquently on this topic. We have a huge amount of diabesity in sub-Saharan Africa. The problem with using a lipogram to identify a person's risk with LDL cholesterol and total cholesterol is that the remnant triglyceride ApoB particles are missed. They have high levels of VLDL and IDL, and the only way we can identify this is by doing an ApoB level. And so there's a discordance. This is the term we use in cardiology. There's a discordance with what appears to be a low-risk lipogram in a diabetic or metabolic syndrome, yet they have a very high ApoB level. And that is because each one of the atherogenic lipoproteins and the various forms of LDL, lipoprotein little a, IDL, VLDL, they all have one molecule of ApoB in each molecule of lipoprotein. And so you can have two identical LDL cholesterols of 3, and yet one of these individuals would have very low ApoB, would be low risk, and at the same cholesterol level with lots of VLDL, IDL, lipoprotein little a, or small dense LDL, they will have very high levels of ApoB. In other words, the lipogram is discordant compared to the ApoB level. Elevated lipoprotein little a has come back into our arena. It went to sleep over 2 decades. I knew about lipoprotein little a 33 years ago, and I used to treat people for elevated lipoprotein little a. The science went silent until 10 years ago, and it's now re-emerged that lipoprotein little a is very rarely documented. I will guarantee in a room of this size, less than 1% of you will know what your lipoprotein little a is. It's present from birth, it doesn't change, and it is a very potent and independent causal risk of atherosclerotic vascular disease, particularly in the 2% of the world's population who have severe elevation of lipoprotein little a, and 18% of the world's population that have moderate to severe elevation of lipoprotein little a, which is between 50 and 100 milligram per deciliter. And this is the lipoprotein little a molecule, and it is both pro-inflammatory, pro-atherogenic, and pro-thrombotic. It has 3 very nasty atherosclerotic, atherothrombotic potentials in the human body. It is 100% correlated to atherosclerotic vascular disease, both coronary and peripheral. It is now the leading cause of degenerative calcific aortic valve disease, which we did not appreciate until quite recently, and a total a risk of stroke and total cardiovascular mortality. And in fact, it has been calculated that the molecule of lipoprotein little a is 7 times more atherogenic than an LDL cholesterol ApoB. So we take our mandate from the 2019 ESC guidelines, and they have taught us a new strategy. And the new strategy is concept 1, start early. 1 in the diagnosis and 2 in the treatment. Concept 2 is to treat early and to treat much more aggressively. Gone are the days of waiting to someone to have an event in their 50s and 60s and then throw the book at them. Rather take the individuals as young adults in their 20s and 30s, separate out the genetic risk of 50% of our population, and treat aggressively to the desired LDL and ApoB goals. And concept 3 is brand new. Instead of using monotherapy, just statins or just lifestyle or just whatever, we now from scratch use combination therapy. And the combination is statin plus ezetimibe plus or minus PCSK9 inhibitor. And so the European Society of Cardiology talks about cardiovascular risk. And they have benchmarked risk into low, moderate, high, very high, and extreme risk. And for each of these risk levels, you have to achieve a LDL cholesterol goal. And you'll see just how aggressive we've become in the very high and extreme risk, getting LDL cholesterols as low as 1.0. And we've got plenty of evidence to suggest the efficacy in hard outcomes in outcome clinical trials, randomized, placebo-controlled, big trials to show lower is better. And this study shows some fascinating evidence. It's a recent publication in 2022, taking people with a heart attack, putting them on conventional statins or conventional statins with an add-on PCSK9 inhibitor, and looking at the plaque morphology with IVUS, near-infrared spectrometry, or optical coherence tomography. And what they demonstrate at the end of the study, in conventional therapy, you're only getting LDL down to about 1.9 with conventional high-dose statin therapy. With the addition of a PCSK9, we're getting LDL cholesterols of 0.6. Very few clinicians will have the confidence to reduce a patient to 0.6. I do it every day in my life for tens of thousands of patients. And this is the sort of outcome that you can generate. Optical coherence tomography is a very good technology for looking at the fibrous cap thickness of a plaque. And near-infrared spectrometry looks at the lipid core. What this study showed was that in the intensive group treatment, you had double the amount of plaque regression, you had double the amount of regression in the lipid pool in a plaque, and you had double thickness of the fibrous cap. And it is these factors of thicker cap, smaller lipid pool, lower inflammatory cells that defines a stable versus a vulnerable plaque. And that's why treating a younger person tends to postpone their events to much later, because they have stable plaque rather than vulnerable plaque. And we know that we've got the tools to do it. High-intensity statin therapy will reduce your ApoB by 50%. Combining it with ezetimibe, 65 to 70%. Combining it with a PCSK9 inhibitor, up to 90%. Yet these are the worldwide figures, ladies and gentlemen. How bad are we doing? This is an observational study of primary and secondary care, very recently published, showing that we're only using high-intensity modern statin monotherapy in a third of patients, ezetimibe in less than 10, and PCSK9 inhibitors in 1% of patients. And these PCSK9s have revolutionized our life as preventative cardiologists. The first generation PCSK9s are extremely effective. The second generation PCSK9s, which is the new small RNA interfering molecules, they prevent the manufacture of the PCSK9 protein in the ribosome. And we get a very good 50 to 60% ApoB or LDL-C reduction by giving just 6 monthly injections of the generation 2 inclisiran. So my last slide. We really do have this concept of disease-modifying agents. And the disease-modifying agents are plaque-stabilizing agents. And we know for a fact that aggressive ApoB lowering to less than 0.5, or ApoB, ApoA1 less than 0.3, and taking LDL cholesterol down to 0.5 or 1.4. And again, I'm not convinced that many of you in this room will be doing this. With high-dose potent statin therapy, ezetimibe and PCSK9 inhibitors. We will be addressing lipoprotein(a) in more detail, because there are 4 drugs in phase 3 clinical trials at the moment, and they reduce lipoprotein(a) anywhere between 90 and 100%. And the phase 3 clinical trials will tell us whether we will prevent aortic valve disease, peripheral vascular disease, coronary artery disease, and stroke. We are attending to the inflammatory component, much like your previous speaker mentioned. We are using anti-inflammatory drugs like colchicine to lower the inflammatory risk. We are using the ACE inhibitors and the angiotensin receptor blockers to stabilize plaque by lowering endothelial shear stress over a vulnerable plaque. We are using dual antiplatelet therapy now in all our high-risk patients, a combination of aspirin and very low-dose rivaroxaban, one of the new anticoagulants. And we are starting to use more SGLT2 inhibitors in high-risk patients, particularly the diabetic metabolic syndrome with chronic kidney disease, with atherosclerotic vascular disease. And we will soon, God willing, be able to use the GLP-1 agonists a little bit better when maybe they are priced a little bit better. These new therapies reduce major adverse coronary events by biological modification of global total atherosclerotic burden. And with all respect to my invasive colleagues who use a 7mm stent to save people's life, I treat 80,000 kilometers of arteries in the human body every day. And this systemic approach is the only approach, in my opinion, to lower cardiovascular events and risk. So, ladies and gentlemen, there's 7 things you just need to know about reversing heart disease and preventing heart disease. It's quite simple because this is the normal paradiagram of life. You're born, you get to about 40, you start getting chronic disease, mostly cardiovascular disease, vascular disease, dementia. But with and I loved your last speaker's keto diets, because I prescribe low plant-based, low-carb Mediterranean diets every day of my life. We keep the atherogenic lipoproteins ridiculously low. We target BMI in every one of our patients. We prescribe exercise in everybody. We keep blood pressure, inflammatory markers, and glycemic control perfectly controlled. And this is the sort of thing that we get. We get what is called compression of morbidity, that you get to end of life with excellent functional state. And in fact, you might get a little bit more life with all your cardiovascular morbidity compressed into the last hours or weeks. Ladies and gentlemen, I thank you very much.
Thank you very much, Dr. Mo. Before we take questions, just a few announcements. First of all, I'd like to thank all our excellent speakers this morning and this afternoon, and especially our sponsors, Ahmed Al-Qadi Hospital, and the 3 people who came all the way from KZN to Cape Town. Thank you very much. And then, of course, our other sponsors, Nutrition Network and Novartis as well. The second announcement is that lunch will be served buffet style outside. Yeah, you can all enjoy a nice lunch, breakfast included. And then before we take questions for those that enjoyed today's session, tomorrow at 9 a.m., same venue, Professor Russ and myself will be speaking about fasting. So if you enjoyed today's lectures, you might want to consider attending that as well. Okay, are there any questions?
Since you use the space for advertising, I have your permission to advertise my talk for tomorrow afternoon, which is obtaining food, a concept nobody has ever discussed. It would fit in perfectly what the ladies in front of you discussed. And I would like to thank, on behalf of all of us, a very big thank you to Dr. Hassan for clearing up the concept of insulin resistance. Nobody could give me a solution to that, but at least she is a remote.
Thank you, Marita. See these one hand up at the back, two hands, three hands. Okay. Four. Okay, we'll start with the lady at the back. You see a mic?
This question is for the dietitian. Just a quick one. You have explained very nicely the dietary times. But why is it that the dietitians are contradicting this? Because there are no national guidelines for the dietitians to follow. So each dietitian we send to, some of them are saying low fat diets, some of them are teaching intermittent fasting, not do that. Some of them are saying no frequent meals. There are no national guidelines for it. Can you put your hand up? Okay. That's a very good question. There is a lot of confusion on why dietitians don't have a very good institution because everybody advocates differently. And one of the reasons why I touched on so many diets was there's no one particular diet. It has to be a combination approach and it has to be individualized per patient. So you have to take their lifestyle into consideration. You have to take the blood work into consideration. You have to take the mental health into consideration. And then obviously, depending on what you've seen holistically, that's how you advocate going forward. And with this obesogenic environment, you have to be cognizant about what you're telling the patient. Um, if you keep it simple, it's really not difficult to get the desired outcome. But yeah, unfortunately, the nutrition world is such, it's constantly changing, and there's just a lot of information and misinformation out there. So you have to go onto social media has a big hand to play in this. You will see a whole host of conflicting information. So unfortunately, to answer your question, if there's no set guidelines, there are many guidelines, but it's how everybody interprets those guidelines. So yeah, I don't know, I hope that answers your question.
Next question at the back.
Yeah, hi. This is for Dr. Kaji. My name is Ibrahim. I'm an emergency physician. And what I wanted to find out, the evidence of insulin underlying most of these chronic complex diseases is becoming pretty clear. Many researchers are saying that dementia is also a feature of metabolic disease and insulin resistance. Identifying metabolic disease in patients who have the clear obesity, hypertension, cardiovascular is obviously quite easy. But I'm seeing many elderly patients who I suspect are having dementia at the end of their life for cardiovascular and hypertension, secondary to that metabolic disease, but many of them look like they're in shape and they're thin. Is this still ascribed to insulin? Is it still believed to be part of the metabolic syndrome? If so, how do we diagnose it earlier to prevent that?
Walaikum salam, nice to see you, Ivan. Yeah, so, we call Alzheimer's type 3 diabetes because of the role insulin resistance has centrally in the brain. But then I think also, as you've seen diabetic patients for a long time, the long-standing, long-term consequences, of the advanced glycation end products and all of that has a role to play in the blood, the vasculature of the brain. So, it's really simple for me. It's simple, but it's not easy. If we were, like my colleague said, it's not I mean, it is an individual approach because if you say to everybody eat ketogenic, you'll lose everybody. You really have to go with meet the person where they're at and take the low-hanging fruit away. So all processed foods, sugar, preservatives, that shouldn't be a part of any diet. So we can start with that. And I mean, start by thinking of these metabolic diseases. If you have a genetic predisposition, the likelihood is you're going to get it at some point in your life. And so you're asking about if there's a way to identify this early. You know, you get the toffees, the thin on the outside, fat on the inside, and they think they can eat everything, but they're metabolically unwell. A simple, HbA1c, a highly sensitive CRP, a fasting insulin blood test, will show you where you're at. There's something that I've set up at Healthcare in Constantiaberg, which is called the Craft test, because most of the glucose intolerance is missed because we stop testing too early. But if you look at Dr. Joseph Kraft, he looked at prolonged glucose testing over 5 to 6 hours and matched the insulin with that. And he found about 90% of people who were told that they're not insulin resistant and their glucose is normal, they were picked up in that. So, we have to actually reinvent the wheel and start to wonder why we're demonizing certain blood markers and what should we be looking at instead. I don't know if I answered your question, but I agree with you. Yeah. 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 So highly sensitive CRP, I actually do test a little bit lipoprotein LP with my patients too. I just want to say my dad, if you don't mind me saying, is type 2 diabetic. Alhamdulillah, he's on no medication. Sometimes his fasting blood glucose goes to about 4 in his fasting. His fasting blood glucose on a normal day is 5 point something, and he eats this way. If you talk to him later, he'll tell you that he's lost weight, how energetic he is. This morning he was pumping weights and jumping before we came, mashallah, tabarakallah. So it gives you energy, and I lost my train of thought. Yes, but the highly sensitive CRP and the serial insulin, if you can see that those markers are off, that's how you can use it a lot of people.
Okay, one last question.
This is to Dr. Moore. I just want to ask, is there any place for regular sort of genetic testing to check for
Yeah, that's a very good question. The only monogenetic disorder we know of is familial hypercholesterolemia. And the problem with the genetic testing, and I've just had this in a number of patients, is one, the test is extraordinarily expensive. It's got to go to America. We don't have assays in this country. And the second problem with familial hypercholesterolemia is that it's only positive genetically in 40 to 60% of patients. So we make a diagnosis of the genetic disorders according to their phenotype rather than their genotype. The phenotype is what the patient looks like and what their numbers are on paper, and what the bedside examination, and whether they have premature subclinical vascular disease or not. So that's our best way in this part of the world to look for the genetic disorders. I've just published a paper on this. It was available in February this year. That your best marker for a genetic disorder in any family is to take the family history. All you will do is pick up all the ancestors who had premature vascular events. So remember, the average European male lives to 80 and the average European female lives to 83. If you've got any family history of anyone dying prematurely, there's a high probability that that's premature vascular disease. And there's your red flag for cascade screening immediately. So to answer your question, we've got no genetic tests for the polygenic dyslipidemias. The genetic test for lipoprotein little a is to just measure the lipoprotein little a, and the genetic tests for familial hypercholesterolemia are unreliable. Because if you get a negative test, your patient will walk away and say, "You don't know what you're talking about, doctor," and they won't go on to treatment.